Welcome back to the second part of the module for the topic of type 2 diabetes mellitus. In the first part, we already covered the basic information about diabetes and prediabetes. Now, I'm going to talk about the management of type 2 DM. In this presentation, I will discuss in detail about management of type 2 DM, with oral glucose medications in detail. Management of type 2 diabetes mellitus. At diagnosis of type 2 DM, a detailed history which focuses on a few key issues which will affect treatment decision should be undertaken apart from assessing for symptoms and presentation of diabetes. Full physical examination including fundoscopy and monofilament test, and baseline investigations should be performed to assess for the presence of arteriosclerotic cardiovascular disease risk factors and complications of diabetes. Diabetes management involves lifestyle modification, medications, and patient education to encourage self-care and empowerment. It is important to take a detailed assessment of newly diagnosed patient with type 2 DM. In history taking, please ask about symptoms suggestive of type 2 DM. It is important to assess history of microvascular and macrovascular complications like neurological, cardiovascular, and renal-related symptoms. Not to forget to ask about visual disturbances and foot problems. You also need to look at the risks that predispose patient to type 2 diabetes mellitus like age, ethnicity, family history, BMI, their lifestyle and comorbidities like hypertension and dyslipidemias and medications that impact weight and glycemic status. For women, please ask history of PCOS, and obstetric history of large babies or GDM. Other important history to look are the comorbidities like non-alcoholic fatty liver disease, dementia, pancreatitis, cancers, and periodontal disease. Please review the medications focusing on treatment regimens, medications intolerance, or side effects. Please ask about complementary and alternative medicine use. Don't forget about the vaccination, example COVID-19 vaccines, pneumococcal and influenza vaccination. Patient should be referred for annual fundus camera assessment, family planning for women, diabetes nurse for education support and to check their foot, dietitian and quit smoking clinic if patient is a smoker. The physical examination should be thorough for newly diagnosed patient with type 2 diabetes mellitus. Please look at BMI, waist circumference, and for adolescent, the pubertal development. Cardiovascular system, eye, feet, and peripheral nerves should be checked. The investigations that should be done in newly diagnosed patient with type 2 diabetes mellitus are fasting plasma glucose, Hba1c, RP, LFT, lipid profiles, urinalysis for albumin and microalbumin if albuminuria is absent. ECG should be done as a baseline. The summary of updates for targets of control. Patients should be counseled about the importance of achieving optimal body weight with lifestyle modification if they are overweight or obese. Hba1c targets have been revised according to individual characteristics. To achieve Hba1c less than or equal to 7%, aim for fasting plasma glucose or pre-prandial glucose targets of 4.4 to 7.0 millimoles per liter and 2-hour post-prandial glucose target of 4.4 to 8.5 millimoles per liter. BP targets are revised to systolic BP 130 to 139 and diastolic BP 70 to 79 mmHg. Lipid, LDL-C, targets are according to CV risks. That is, for moderate risk, the target is less than 2.6 millimoles per liter. For high risk, the target is less than 1.8 millimoles per liter. For very high risk patient, the target is less than 1.4 millimoles per liter. Hba1c target should be individualized based on patient profile. Therapy in most patient with type 2 DM should be targeted to achieve Hba1c less than or equal to 7%, or a more aggressive target less than 6.5% should be attempted in those with long life expectancy, no comorbidities, and in those whose targets can be achieved without causing severe hyperglycemia. O-less tight target 7.1% to 8% are for elderly patients, short life expectancy, presence of comorbidities and for patient with hyperglycemia unawareness. Aims of treatment. The short-term aim is for relief of symptoms and acute complications. The long-term aims are to 1. Achieve appropriate glycemic levels. 2. For reduction of other CV risk factors. 3. To identify and treat chronic complications. 4. To optimize quality of life. Multiple risk factor reduction. The ABCs for type 2 DM has been shown to reduce long-term complications and mortality, and it's sustained beyond the intervention phase. Always remember the ABC for type 2 DM. A for Hba1c, to target the glycemic control. B for BP control. C for cholesterol, to target for lipid control. Now I will move to the topic of medications. I will focus only on oral glucose-lowering drugs, OGLDs. Insulin therapy will be discussed by other presenter later. The OGLDs that I will cover are Biguanides, metformin. Sulfonylureas, SU. Incretins, dipeptide, L-peptidase 4 inhibitor, DPP4I. Sodium glucose cotransporter 2 inhibitors, Sglt2I. Biguanides, or usually known as metformin. It lowers blood glucose, especially FBS, by decreasing hepatic glucose production. It not stimulate insulin secretion and is usually not accompanied by hyperglycemia if taken as monotherapy. It reduces Hba1c by up to 1.5%. Use in combination with other OGLD, it has synergistic effect to further reduce plasma glucose and may reduce insulin requirement. Most common side effects are nausea, anorexia, and diarrhea. In order to minimize the side effects, takes metformin together with or after meals. It is best to start with single daily dose, followed by weekly titration. Vitamin B12 deficiency is recognized uncommon long-term complication. Lactic acidosis is rare, 1 case per 100,000 treated patient, and usually associated with renal impairment. Metformin is weight neutral or may result in mild weight loss up to 1.1 kilograms. Doses beyond 2,000 mg OD so not confer any further glycemic benefit and significantly increase GI side effects. Low-dose metformin can be safely prescribed to lactating mothers. This table shows the metformin formulations and dosages. Sulfonylureas, SU reduce plasma glucose by increasing insulin secretion with an average Hba1c reduction of 0.4 to 1.62%. The major adverse effects is hyperglycemia. The risk is higher in renal impairment, liver cirrhosis, and elderly. Weight gain in the range of 1.3 to 3.3 kilograms is common. SU should be taken 10 to 30 minutes before meals and can be combined with other OGLDs to improve glucose control. SU are safe with regard to CV risk. There are 2 trials on these issues. 1. Tosterit. It is a multicenter, pragmatic trial over 5.7 years, found incidence of CV events similar with SU predominantly, glimepiride and gliclazide versus pioglitazone as add-on treatment to metformin, with the conclusion that SU and pioglitazone were equally safe with regard to CV risk. 2. In the recent CVOT, Carolina trial, of adults with type 2 DM and elevated COV risk, the head-to-head RCT comparing linagliptin, a DPP4 inhibitor, to SU, that is glimepiride. This study demonstrated non-inferior CV safety for linagliptin compared to glimepiride. This has eliminated the stigma of elevated CV risk associated with SU. This table showed the SU formulations and dosages. The only SU available in pharmacy at KK is gliclazide Mr. 30 mg. Alpha-glucosidase inhibitors, AGIs, it reduces the rate of absorption of polysaccharides in the proximal small intestine by inhibiting glucosidase enzymes. They should be taken with main meals. It lowers postprandial glycemia without causing hyperglycemia. It reduces Hba1c by 0.5 to 0.8%. AGI significantly reduced risk of incident T2DM from IGT by 23%, whereas in those with IGT or T2DM, the impact of CV outcome was neutral. The common side effects are bloating, abdominal discomfort, diarrhea and flatulence. This table shows alpha-glucosidase inhibitors formulation and dosage. Incretins, DPP4 inhibitor and GLP-1 analog. The incretin system has become an important target in the treatment of type 2 DM. After meals, incretins are released. These augment glucose-induced insulin secretion and suppress glucagon release, thus reducing hepatic glucose output and reducing plasma glucose in a glucose-dependent manner. Incretin effect markedly decrease in type 2 DM, resulting in delayed and reduced insulin release. Lack of suppression of glucagon release after a meal. Incretins, at pharmacological level, reduce gastric motility, thus slowing glucose absorption, and increase satiety by acting on centers in the brain. Dipeptidyl peptidase 4 inhibitor. DPP4 inhibitor lower Hba1c by 0.5 to 0.8%. They are weight neutral and have a minimal risk of hyperglycemia. They are efficacious and safe in the elderly and all stages of diabetic kidney disease. DPP4 inhibitor cardiovascular outcome trial have confirmed cardiovascular safety. Saxagliptin is not recommended in patients with pre-existing heart failure as it has been shown to be associated with increased risk of hospital admission for heart failure. This table shows DPP4 inhibitor formulation and dosages. Majority KK in Selangor has vildagliptin in their formulary. Sodium glucose cotransporter 2 inhibitors, Sglt2 inhibitor. This class of drugs selectively inhibits Sglt2, a transporter in the proximal tubule, thus reducing glucose reabsorption leading to an increase in glucose excretion. It reduces Hba1c by 0.5 to 1%. Additional effect of treatment include weight loss, 1.8 to 2.7 kilograms. Reduction of SBP, 2.7 to 4.8 mmHg. Reduction DBP, 1.8 to 2.0 mmHg. It can be combined with other OGLD, GLP receptor agonist or insulin to improve blood sugar control. Sglt inhibitor and cardiovascular. Sglt inhibitor, in empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus patients and Canvas study have been shown to significantly reduce major adverse cardiovascular event endpoints in T2DM with atherosclerotic cardiovascular disease. Sglt2 inhibitor have been proven to reduce hospitalization for heart failure for primary and secondary prevention in few studies. Sglt2 inhibitor and renal. Efficacy of glucose-lowering effects of Sglt inhibitor are independent on renal function and not recommended for patients with moderate to severe renal impairment. Sglt2 inhibitor reduce intraglomerular pressure independent of glucose levels. Sglt inhibitor have been shown to be effective in reducing renal endpoints. Reduction in macroalbuminuria, doubling of serum creatinine, ESKD and renal death, down to eGFR of 30 in patients with DKD. Do not initiate at eGFR less than 30 but may continue if already initiated. Side effects of Sglt2 inhibitor. Significantly increase in urogenital mycotic infection and UTI. Small but significant increase in risk of DKA, volume depletion and osmotic diuresis. Cases of euglycemic diabetic ketoacidosis, EDKA, have been reported in patients who are on Sglt inhibitor with intercurrent illness, may need to withhold temporarily Sglt inhibitor during intercurrent illness or surgery. This table shows Sglt2 inhibitor fixed dose formulations and dosages. This group of drugs are not available in all KK in Selangor. However, you can advise your patient to purchase it at local pharmacies. This is the treatment algorithm plan for newly diagnosed type 2 DM. In all diabetes patient, please emphasize the importance of implementing lifestyle modification for overall management of type 2 DM. The decision on starting monotherapy, multiple OGLDs, or adding on insulin, depending on the Hba1c and fasting plasma glucose level. If Hba1c is less than 6.5% and fasting blood sugar of less than 6, you can start on metformin monotherapy. However, if postprandial is more than 11 millimoles per liter and or metformin is not tolerated, you may consider to give meglinetide, alpha-glucose inhibitor or DPP-4 inhibitor. If the Hba1c is 6.5 to 7.4% or fasting plasma glucose is in between 8 to 9.9 millimoles per liter, you can initiate mono or dual therapy with metformin or sulfonylurea, DPP-4 inhibitor, GLP-1 receptor antagonist or Sglt2 inhibitor. If Hba1c is 7.5 to 8.4% or fasting plasma glucose is in between 8 to 9.9 millimoles per liter, you can give dual combination therapy with any combination of the drugs listed. The triple combination therapy with any combination of the OGLDs and insulin can be initiated if Hba1c is in between 8.5 to 10% or fasting plasma glucose is in between 10 to 13 millimoles per liter. If the Hba1c is more than 10% or fasting plasma glucose is more than 13, you can start on basal or premixed insulin therapy with combination therapy. Hba1c remains an important target. If glycemic targets are not achieved, intensification of treatment should be made every 3 to 6 months. This slide shows treatment recommendations for patients with type 2 DM on clinic follow-up. 3 to 6 months after initiation of therapy, please look at the Hba1c level of individualized target, with lifestyle modification and existing therapy. If Hba1c above 0.5 to 1% above target, you need to add one additional glucose-lowering drug from different class. If Hba1c above 1 to 2% above the target, consider 2 glucose-lowering drugs from different classes, and if it is more than 2% above the target, you should initiate insulin, and/or add GLP-1 receptor agonist. The intensification of insulin should be done if patient is already on insulin treatment. This table shows efficacy of various glucose-lowering drugs. Please have a look at the Hba1c reduction, side effects like hyperglycemia, weight change and GI symptoms. You should also look at the use in patient with congestive heart failure, cardiovascular disease, and in diabetic kidney disease. This table shows clinical monitoring schedule for other risk factors in patients with type 2 DM. Please refer to this table to guide in terms of monitoring at initial visit, at every follow-up and at annual visit. Self-monitoring of blood glucose, Smbg, is a method of choice in assessing glycemic control and prevent hyperglycemia. It is a part of an educational initiative. Smbg should be recommended in patients treated with insulin and desirable for those on OGLDs. Frequency and timing of Smbg should be tailored based on the patient's needs, including glycemic status, drug therapy, treatment goals, and lifestyle. This table shows the recommendations for Smbg if patient on diet therapy only or on oral glucose-lowering drugs. You should advise patient to check the dextrostick pre- and post-breakfast, post-lunch, and post-dinner. If patient on insulin therapy, it is recommended to check for 7 points monitoring. This slide shows dosage of glucose-lowering drugs in chronic kidney disease. Please refer to this table to see adjustment of OGLDs in CKD patient. This slide is the continuation of dosage of glucose-lowering drugs in CKD. Thank you for your kind attention. If you have any question, please ask your FMS for further clarification.